Hello, my name is Dr. Susan Swim. I'm very, very fortunate to have a wonderful guest with us today, but I'm first going to describe a little about myself and what I do. I found myself being a clinician in the late 70s and early 80s before there really was a stronghold of the medicalization of what normal, or that we saw people through the lens of deficiency and what was wrong with them instead of like what happened to them. And I was truly, truly fortunate to help open up a mental health clinic in 1983, along with some colleagues who had trained with me at the Houston Galveston Institute, where we trained with an amazing man called Harry Galician, who really opened up my eyes a lot to what was going on within the mental health field, as well as Harlene Anderson, who still promotes this work today. And one of the things that I thought was so important in working in this community mental health is that we had two tracks. We had one track where people would come in and they would see the psychiatrist because they'd seen the psychiatrist before. And then we had another track that the new people never saw the psychiatrist because it really wasn't something that we were trained that people needed to go in and talk to a psychiatrist unless, of course, they wanted to. And at that point in time, nobody wanted to go see a psychiatrist. So the psychiatrist came in once a week, and his only patients were the ones that had seen him previously. And so we saw a plethora of people that were going through difficult times. And usually by the time you get to a mental health clinic, you have used up all of your private insurance. So these were people that had been diagnosed as psychotic or diagnosed with probably major depression at that point in time or some type of life-threatening symptoms. And every one of those people did fine. Nobody went to the hospital. Nobody went on medications. We didn't use the words of psychology. So we never said, I've never said to anybody in my whole entire life that I think you're depressed or that I think you're schizophrenic or I think that you have an eating disorder or I think you have anything. I've talked with people about what they're going through. And even though they might use those words initially, what I find is that when we get into conversations about what happened to people, is they start using words that, for me, more accurately describes what happened to them. And when I was thinking about this interview this morning, I was thinking about that most of the people in my life that have had experienced and talked about very severe symptoms had very difficult situations. And so for me, it's been like a heartbreak of a loss, of grief, of some of the worst things that can happen in your life. And I do think that as human beings, we've always responded to that in different ways. But psychiatrists always try to define it that we have to eliminate the symptoms and somehow prevent them by doing who knows what. I mean, like, you know, when I in the 70s, electric shock was so popular. And I always saw this type of work as something that we had to be creative and find different ways to be able to do things. So I've never suggested somebody be on medications or in a hospital, not because I don't like those things, but I never really saw those things that were going to be useful to them. If someone had asked me like, well, please, can I go? I'd be like, well, let's figure it out. But nobody actually wanted to do that because as we were talking earlier, Robert, that once they kind of find out what the trajectory of that, they might have different ideas. Okay, so that stops me. And then we're going to be putting on a conference in January. We try to do this quarterly if we can to help raise awareness for both consumers and practitioners about the ideas that we're going to talk about. So again, I'm so honored to have you with me and leave this open to you then.
Well, my name is Bob Whitaker. Uh, I've written several books about the history of psychiatry, and I run a website called Mad in America. It's a nonprofit organization. And what we try to do on Mad in America is, well, our belief is that this current disease model of care that we have, it's failed. It's failed in many dimensions. It's failed scientifically, but it's failed in terms of outcomes, public health outcomes, and outcomes for individuals. So the website's really devoted to rethinking this paradigm of care and helping create a new one. And that involves a couple things. And one thing that does involve is becoming aware of what sort of outcomes are we getting with. It's really two things. We have this model of care that says these things are diseases inside the individual, and you have to fix the individual's head. Okay, whether it be whatever the diagnosis might be. And we even heard about chemical imbalances and drugs fixing chemical imbalances. Well, that story of science that we have drugs that fix chemical imbalances in the brain. It's just not true. They never found that chemical imbalances were the cause of depression or schizophrenia, and that the drugs, rather than normalize neurotransmitter activity, actually abnormalize it. So that's one failure. The second failure is public health outcomes. We've adopted this disease model in 1980, and the burden of mental health in our society just keeps going up and up and up and up and up. And now it's like just extraordinary proportions. So obviously, this conception and this way of treating it with drugs as a first-line therapy is not working. That's at a societal level. And then when we just look at the long-term course of people who are diagnosed, say, with depression or bipolar or even schizophrenia, and we look at their long-term outcomes, and we compare those outcomes to what sort of spectrum of outcomes do we see in nature, the natural capacity to recover. And what you see with this paradigm of care is you see increased chronicity. I'm talking about the drug-based form of care. You're more likely to remain symptomatic. You're more likely to remain functional impaired. And you're going to have other adverse effects, often physical effects. Well, there's emotional, of course, numbing out and that sort of thing. So on all three levels, this is a failed paradigm of care. The science isn't true, poor public mental health outcomes, and it's on an individual level, you'll see that it's a form of care. If you're compliant with it over the long term, it actually increases your likelihood that you'll remain, having trouble, symptomatic, functionally impaired, and that sort of thing. So that's what we do. We're really trying to challenge the existing narrative. We're trying to show the ways it's failed. And then we're also trying to highlight alternatives that have much better sense of a much better capacity to help people get well and stay well. And one of the small things about this is this. There's actually a great capacity in nature, naturally, for people to recover from episodes of episodes of depression, even an episode of mania, even an episode of psychosis. So we've under the disease model of conceptualized these things as chronic illnesses. You can take your drugs, but they're always going to be with you. And that's just not true. And the message of hope that you will find on Mad in America is that so often these difficulties can be episodic. You don't need to become a mental patient for life, and you don't need to take drugs for life. So that's what we're doing. And we do it by reporting on the science. And we do it also by hearing people with lived experience tell their stories. And so you'll see two things on our website. You'll see both a criticism, a critique of existing narrative, the existing therapy. And what you'll see, though, when we present alternatives is this alternative vision is so much more optimistic about really getting your life back. So that's what we do.
Well, and I really love what you said about, well, I love your website, I love your work, but I really love what you said about natural. Because at one point in time, what we started doing when we opened up Now I See a Person Institute, um, and it's devoted to seeing people as people, not as a diagnosis, not as deficiency that it might have labeled them or defined them in the past. And we have found that when people no longer see themselves as a diagnosis, that natural takes over. And you never know what way it's going to take, but it's a very natural process. And you know, we were talking about this a little bit previously, but helping, I don't know which is more difficult, helping consumers know about these options or helping practitioners know about these options. Because, as being a clinician in the field since the 70s, it's just been amazing that we've had all of this research that this is a biological component when there's no there's no I was going to say there's no science, but I hate to say that kind of word because it's such a political topic. Does
What,
that?
when we can tell if we even look into the scientific literature, there's no known characteristic pathology. So they haven't identified a specific pathology that underlies depression or a specific pathology that underlies mania. Now, there can be a lot of pathways to these difficulties, depression, mania, whatever. And there certainly can be physical pathways, poor health, that sort of thing. There can also be environmental pathways where creatures exquisitely designed to be responsive to our environments. And so when we are in difficult life situations, jobs maybe, or divorce, or we've lost someone close to us, or we're in a job that provides no meaning in life. All these things can, take a toll on us. Disease can take a toll on us too as well. But the real point of this is there are many pathways to end up with these symptoms we call depression or anxiety or psychosis or mania. That's the first thing. There is no characteristic pathology. And then the third thing I think that's so important is that if you reconceive of things, that we human beings are so exquisitely responsive to our environment, well, then you know that if you change the environment, you have every chance of helping people get well. We have this resilience inside us. And I think one of the things you just said, Susan, is so important too. With the disease model, this starts to become your identity. I have depression, I have mania, I have schizophrenia, I have ADHD. And so that starts determining how you conceive of yourself. The diagnosis becomes a way of conceiving of yourself. Now, if you say the diagnosis is not a valid thing, it's not a valid medical term, and you reject it, well, now you just see yourself in this larger current of human beings struggling through life, right? And you no longer see yourself as defined by some sort of thing that makes you the other. But as soon as you leave that diagnosis behind, you can start saying, yeah, you know what? I'm struggling in ways with my emotions, maybe my mind, but you know what? That's part of the human struggle. And you can stop pathologizing yourself. You can stop othering yourself. And once you do that, that's part of the pathway to getting better. Is just seeing yourself as a human being trying to struggle with things. And others human beings struggle too. And so often they struggle for a time and they get better. That's if they don't make it into a lifelong pathology in their own mind.
Well, and that's the hard part because that dominant discourse is so extremely, I mean, like, it's crazy.
Yeah, we gotta escape from the dominant discourse. We gotta create a new discourse.
And so if you were giving like some of your wisdom, because you have written um countless books, well, maybe not countless, but you've written, some wonderful books. And what it I had really wanted you to be able to join us in January, but we're gonna like tie you down and be able to get you at some point in time. But what for us, trying to help people raise awareness, in your opinion, in your expertise, what are some of the things that maybe we can address in this meeting together in January?
I think in a big fashion is people organize their lives around narratives.
Mhm.
And societies organize themselves around narratives. And so the big thing I can think a conference can help do is to escape the narrative we've been in.
Mhm.
So, like I said, we've been in this disease model narrative, and this arose in 1980 with the publication of DSM-3, the third edition of the APA's Diagnostic and Statistical Manual. And what that narrative does, it locates the problem inside the head of the individual, right? Your chemistry of the individual. So you try to fix that chemistry. And what I was saying is, and that's what we told, we have these drugs supposedly that fix the chemistry. Well, that's not a scientific story. That was a story that was really born to elevate the prestige of psychiatry, that they were treating real diseases. And we've been with it. It's 2020. Well, your Congress is going to be in 2026. We've been with this for more than 45 years and it hasn't worked. It's
Mhm.
not scientific. It's the burden of mental disorders has dramatically increased, and long-term outcomes for individuals of these categories have worsened. So we need to, your conference can help us see that failure of that conventional model. That opens the door to seeing things differently. And if you see things differently, you start to say, let's think about the capacity to recover in nature. What does it mean to be human? What it means to be human is to struggle with your mind. We're very responsive to our environment. So one of the things you want to look at if you're depressed is what's your environment like? Or if let's just say our children who aren't paying attention to school. Well, and they get diagnosed with ADHD. Well, what is their school like? You really want to be 8 years old and go sit in a chair for 7 hours and then go do homework? I'm not sure that children are built for that sort of thing. And by the way, just remember, like for a while, like remember like a 3-year-old and how curious they are. I'm a grandparent right now. Oh my God, 3-year-olds are so freaking fantastic. They're so curious about the world. They're eager to learn. What they're not eager to do is go sit in a chair for 6 hours. Okay, so just let's remember that environments matter and meaning matters. Good diet matters. Shelter matters. Having a good social life matters. Having friends. So, what I would say your conference can do is help reveal the fact that this one paradigm has failed and we got to get rid of it, but then start replacing that paradigm. It's not just that this one has failed, but what do we know? We know that people are responsive to environments. We know they can be resilient. So if you can start changing the environment, get rid of this pessimistic chronic thing, you have a new narrative. And it's a new narrative filled with hope and kindness and a sense of that rather than othering the people as abnormal, you say, well, we're sort of all in this together. And let's help ourselves get to better places.
Absolutely. I do love the idea of hope because I think that when people have hope, that naturalness to open up possibilities just flourishes. And when we don't, like it's just being in that kind of black box. So I know that we're on a time schedule and I want to honor that. And so I just so much appreciate us having this time to talk, and it won't be our last because I'll track you down somehow. But I appreciate so much
Okay. Well,
today.
thanks for having me on, Susan, and I wish you the best with your conference.
Thank you. Thank you. You too.